She's co-chair of ECHO for Occupational and Environmental Medicine and for Return to Work of Public Safety Personnel at IWH. I welcome you, ma'am, today. But before we have Dr. Andrea, I would like to invite Dr. S.L. Yadav, sir, to give his inaugural lecture. As we all know, sir is a senior professor, Physical Medicine and Rehabilitation at AIIMS, New Delhi. He is also the president of our Association of Pain Physiatry. Sir is the acting member of various international organizations like WFNR, ISPRM, ISPO, ICOS, and sir has also been the former president of IAPMR. He's having over 50 publications in peer-reviewed journal, and he has a special interest in MSK, regenerative medicine, amputee rehab, and neuro rehab. And I'm very happy to say that I share the same institute with Dr. Yadav for passing off my MD degree, MD-PMR. We both are pass outs of SMS Medical College, Jaipur. And I would like to invite first Dr. S.L. Yadav, sir, to give a briefing about what app is all about and our future endeavors. Over to you, sir.
Yeah, thank you, Chandan, for your kind invitation and introduction and invitation. Actually, my task is just to begin with, as a president, like how it was formulated, this association of pain physiatrists, and what's the objective of this association, and what we are really looking forward to have, roping in the various pain specialists abroad so that we can really concretize something great in pain medicine as a rehabilitation physicians. So that's main objective of our meeting. So I'll just share with you. I'm sorry that I'm having very bad for today. Sorry, I stuck. There is some problem. So I think I'm visible, that my slides are visible now.
Yes, visible, sir.
Oh, okay, great. So we thought of, while we came with this society to have some scientific and academic activity in the field of pain, and which is like regarding the awareness about the pain and how really it could be managed. And also that people who are indulged in the pain management, such as the anesthesiologist, nowadays neurologists, orthopedic surgeons, and other medical field who they probably are into the pain medicine. So how we can club with each other. So that's what our aim, to have the scientific body through, organizing in the future for various CMEs, workshop and conferences. And we would like to rope in the pain as a prime factor to manage in the rehabilitation medicine area, which is generally like we earlier used to do for pain management, like electric modalities, exercises, and other program. Now we are just converting ourselves to various interventions to manage the pain in day in, day out practice in the physiatry. So our vision is just to make the physiatrists at par with the international standard in the area of rehabilitation and the pain management, to work together along with, our counterparts abroad in the world. And since we are in physical medicine rehabilitation, we know that what is the genesis of pain, how it's being evaluated, so we can take better care for the pain management as far as other counterparts, our colleagues are concerned, who they are managing into the pain, because they are just hitting to crush the nerves which are really responsible for the carrying pain. But here, as a physiatrist, we might go as a holistic approach to reduce down, to understand better, and how really we could standardize the pain practice in our part of the world by using ultrasonic or C-arm machines to have, better exposure of the tissue where we need to inject. Earlier, we were just doing the blind procedures. Sometimes we are into the place or sometimes we are not into the place. So failure rate was pretty high. So we thought of like to standardize some procedures where we could manage the better pain for having the better outcome in rehabilitation medicine. So our mission is to promote innovation in the pain management. We are looking forward to be the champion research which led to the breakthrough through our physiatry group or physical medicine rehabilitation expert, and at the same time to elevate the standard of care among pain physiatrists for patients around the world. So to go into hand in hand with our international colleagues for the involving in the pain management. So ultimately, we will impart through our society that what are the advancing education in pain physiatry. So what are the gaps and how could they can be bridged together to foster the excellence in the pain management. So we are into the process for having the comprehensive curriculum, course development, hands-on the clinic exposure workshop, interdisciplinary collaboration with our colleagues who they are into the pain management. What are the better technologies are available, how we can really innovate, which could be indigenous or cost effective for the pain management. And again, we are looking forward to have the research and the evidence practice, which is the need of the hour today, and also continuing the professional development so that we can outreach every corner of the country. So this is all which I would like to share now. Over to Chandanpreet, to our main speaker for today's meeting, Dr. Andrea.
Thank you, sir. Good evening. Thank you so much, sir. Can I have Dr. Andrea now, ma'am?
Yes, I'm here. You let
Good
me
evening,
know.
ma'am.
Do you want me to start?
Yes, sure.
Yeah, and let me know. I have 38 slides.
Yes.
What time do you need to stop? You want me to stop talking?
Ma'am, you can take your time. If the time's running out, we'll give a tinkle. But I think we should be
Okay.
good with it.
I
And
think
thank
I'm
you so
able.
much, ma'am. Very much welcome to you joining us here.
Okay.
Sure.
Thank you so much. I'll try to talk for maybe 40 minutes, maybe 35, 40 minutes, and then leave some time for questions.
Sure.
I'll try to do that. Okay.
Sure.
So let me share my slides I have here. And thank you for inviting me again. And I love talking about this topic. And not only this, but I love talking with physiatrists. I am also a physiatrist, and it's an honor to be talking to colleagues in India today because I chose physiatry as my specialty because I wanted to treat pain. And I found physiatry was the best specialty to treat people with pain and chronic pain. I had some experiences myself when I was young with pain, and I decided to become a specialist in pain. And I think physiatry is the best specialty. I don't know if there are any anesthetists here today, but I think anesthetists are great for blocks and injections. But to examine a person with chronic pain, anesthetists are good for acute pain, post-operative pain. But for chronic pain, because it involves a biopsychosocial aspect, and our patients have disability, it's an invisible disability, I think we are the right specialty for people with chronic pain. So, okay, I hope you can see my slides there.
Yes,
So, thank you. Thank you for the feedback. So I hope at the end of this brief, 40 minutes presentation, you will be able at the end of this to explain the 3 mechanisms of pain. You will be able to discuss neuroscience of chronic pain, and you will be able to select the right treatment to the right patient at the right time. So I have some conflicts to declare because I receive grants. I am on many advisory committees for workers' compensation. I have an unrestricted grant from a consortium of pharmaceutical industry. They produce generics medications in Canada. If I talk about my YouTube videos, I do get paid when the advertisements are shown to people. Sometimes in my videos, I mention products for patients to buy, and I link to Amazon, and I am on an affiliate program. If I mention my book, this one here that is behind me, I do get royalties from my book, and I also have online courses for healthcare professionals that are paid courses. Okay, so let's start about what is pain. I think we all know what is pain because we feel pain, and but what is the science of pain? And very few people know. I did not learn this in medical school. I graduated in Brazil. I did my medical residency, medical school and residency in physiatry in São Paulo, Brazil, and then I immigrated to Canada 27 years ago. And I practice here in the pain clinic at the University of Toronto. But I did not learn in medical school what is pain. Everybody talks about pain. Pain is the number one cause why people go to the doctors. But the science of pain has not been so well understood. What happens until probably 1965, when Melzack and Wall at McGill University in Montreal, they started studying the gate control theory, what happens with the pathways of pain. And then there was an explosion of pain science with the inauguration of the International Association for the Study of Pain, IASP. So if you are a physiatrist interested in pain, I highly recommend you to become a member of the ISP because they produce the journal Pain, but also conferences, a lot of webinars, and they are the international organization that defines the terms. Like they are the ones who define what is pain, what is chronic pain, and there are a lot of physiatrists at the ISP. So pain is this sensation that we all know. If you put your toe on fire, there is this red, as we call this the ascending in pathway that brings that message to the brain. And actually it is at the brain that the pain experience is interpreted. So when we talk about chronic pain as a disease, we're basically talking about a brain disease because it all happens in the spinal cord, the central nervous system, but also a lot of changes happen in the brain. And we know that chronic pain, when acute pain transforms into chronic pain, it becomes a different disease. We're going to see this later. So pain is an interpretation, it's the brain interpreting what is going on around us because it's the alarm system of our body. Basically, pain is the alarm that has to alert us when something dangerous is happening to our body, threatening our life. Are we in danger or not? Should we run? Should we stay? The brain is making these predictions based on past experiences and future expectations. Did you know that a person can feel pain without nociception? That when I ask this question, a lot of people say, what? How can someone feel pain? They say that they are in pain, but there is no nociception. Can you give me 2 examples? One is phantom limb pain. You probably saw people with amputation. I hope you are physiatrists that saw people with amputation. There is no nociception. They feel pain in the foot, the hand, that doesn't exist anymore. So there is no nociception. What is another example of pain without nociception? Fibromyalgia. So they feel pain all over their body, but there is no nociception happening. Like if they feel pain, every single muscle of their body, every single part that you press, they have pain. It doesn't mean that there is nociception happening there. It's a malfunctioning of the pain system. And also, a person may have nociception without pain. How can that happen? You probably have had patients that they were injured, especially if they are injured under a very stressful situation, or you saw someone with an injury in front of you and they don't have pain. I see a lot of people with scars and ulcers. They have they have a burn and they don't have pain, or they have a muscle tear and they don't have a pain. They have sometimes they are in a war zone. Some people, there are a lot of reports. There is a very nice publication during the First World War that this, I think he was a physiatrist, he was there, and he noticed that 1/3 of the soldiers who came to the camp with a serious injury, like they lost a toe, they had a gunshot, 1/3 did not have pain. So it's possible, because remember, it's all the brain, it's all done in the brain. So what is chronic pain? So we're talking mostly about acute pain. In physiatry, we see a lot of acute pain, but most of what we do and we see in physiatry is chronic pain. So what is chronic pain? Chronic pain is a different disease, because chronic pain now involves that injury that our patient had is healed. If the patient had an injury to the toe, a fracture, a ligament injury, the body heals and now they have a scar, and scars don't hurt. But why they continue having pain is because of a lot of changes that happened in the pain system. Remember, the discovery of the pain system is new, it's about 60 something years. It could be peripheral sensitization and cortical reorganization, okay? So again, the field of pain science has exploded in the last 6 years. I can't keep up. Every month I receive the journal Pain. It's only one journal produced by the ISP, and I read every single article that is published here, not the animal ones. The animal ones I don't read, but the clinical articles I read. And it's amazing, the explosion, how we are discovering these changes in the pain system. So I usually, when I explain this to my patients, I say, the pain system is like the alarm system. And what is a system? A system is a group of organs with a function. So if you say the digestive system, the respiratory system, the cardiovascular system, the reproductive system, they all have a group of organs and they have a function. So the alarm system, the organs that compose the alarm system is basically the brain, the spinal cord, the peripheral nerves, the nociceptors all over our body, but also the immune system and also the endocrine system. So we have the pain system comprises all of this. It's the neurological, endocrine, and immune system with the function to protect us from danger. So that's the function of the alarms, the pain system. So if we compare the pain system in our body with the alarm system in your house, so if you live in a house and you have an alarm system there, you know this box here in the wall. So what do you do with the alarm system of your house? You install sensors for danger, right? You install sensors, a smoke detector, breaking. If some robber enters your house, you want the alarm to alert you in the middle of the night that there is some intruder to your house. You may also, you can put all kinds of sensors in your house. So we have those sensors for pain all over our body. Our skin is very much innervated with all kinds of nociceptors and sensors for danger. Or internal organs, they also have sensors for pain, but they're not so specialized like the sensors for the skin. And they cannot localize so well. So the visceral pain is not so well localized like the skin. But we have those sensors. They send the wires to this box in the wall, and this box on the wall will communicate with the alarm company, and the alarm company will then decide, okay, should I send the ambulance, the police, or the fire truck to this house? So our brain is the one that interprets these sensations, and the brain is the one that will get all this information from the nociceptors, and will say, what do I do? Should this person go to emergency? Well, but if a person has fibromyalgia, they have pain for 5 years, 10 years, 15 years, there's nothing wrong with their body. They don't have nociception So every time that they have pain, should they go to emerge? No. What is wrong with a person with fibromyalgia? We will see. Okay, that's what I want to teach you, the 3 types of pain that I didn't invent them. It was the International Association for the Study of Pain, ISP. So after the fire, the acute pain has been resolved. The fire trucks came, they put up the fire. There was a fire in the kitchen, but now the kitchen is renovated. There's no more fire. There's no more acute pain. The injury is healed, but the person continues having pain. What is going on? It's almost the same thing as the kitchen is beautiful. The kitchen is renovated, but the alarm continues saying, fire, fire in the kitchen. I detect danger in the kitchen. What do? You don't call the fire truck. You don't call the fireman. You call the alarm company and you say, please fix the alarm. Maybe during the fire in my kitchen, the alarm was broken, damaged, and now we need to fix the alarm. So that's basically what chronic pain is. The initial injury is healed, but the alarm continues going on and on and on. So the person with chronic pain, they feel like this. And usually when I show this picture to my patients with chronic pain, they start crying. They look at me, they say, Dr. Furlan, do you really believe me that I am in pain? I say, yes, I believe in you. You have a real pain. You are living like in a house that it looks like the house is on fire all the time, like because the alarm is making a lot of noise, but nobody sees the fire. And they come to you and they do MRIs, they do CT scans, they do X-rays, and people say, but there's nothing wrong with you. I don't know what's wrong with you. And they start giving you medications and telling you that you have to lose weight, or maybe you are too stressed, or maybe this pain is in your head, or I don't know what you have. Go do some physiotherapy. And the person becomes dismissed, and they become depressed, they can't sleep, they become debilitated, they stop working, they stop living. And you probably have seen people like this, that their life is a mess. They're very disabled. And then they send to the physiatrist saying, oh, do something with this person. So you need to see the person as a whole. What's going on is their alarm system of their body, the pain system, is terribly on fire. So their brain is overwhelmed because the brain is receiving a lot of messages of danger, but you examine them and you don't find anything. So this is what the 3 types of pain are. And I have a video on my YouTube channel that I explain this. It's a video for patients where I explain this in very lay language. You may have chronic pain because you have nociception. Okay, some people may have, like if they have rheumatoid arthritis, that their joints is always inflamed, that's nociceptive pain. You can see the inflammation there, you can see the redness, you can see the lesion. So they have nociceptive pain. But usually nociceptive pain is more acute and the body heals. Or they may have neuropathic pain. They may have a diabetic neuropathy that is destroying the nerves, the peripheral nerves, and they have that peripheral neuropathy. That's neuropathic pain. That is a different mechanism. Or carpal tunnel syndrome, that we know that, the pain is here, or they have shingles and now they have postherpetic neuralgia, or they had a stroke, or they had a spinal cord injury, or they have multiple sclerosis. Those are neuropathic pain. But those are rare. Well, maybe in our practice, maybe it's not so rare because we see those patients. But in general, in the world, when you talk about chronic pain, nociceptive chronic pain, neuropathic chronic pain, they're very rare. When we talk about chronic back pain, 90% are nociplastic. And nociplastic pain is that kind of pain that is the alarm system that is malfunctioning, okay? So we do need, the World Health Organization, WHO, just released in December a guideline to treat chronic primary low back pain. Chronic primary means it's primary pain. The mechanism is nociplastic. Primary pain means it's not secondary to nociception or neuropathic. The WHO concluded that 90% of all chronic back pain comes from nociplastic pain mechanisms, Okay, so we do need to understand the neuroscience of pain, because if you don't understand what is happening with these nociplastic pain mechanisms, you're going to keep treating your patients as if they had nociceptive and neuropathic pain, but they don't. It's almost like the alarm system of the house is malfunctioning, and you're calling the fire truck, police, and ambulance every day. They're going to come every day to the house and say, the house is not on fire. You need to call the alarm company. So if you want, I have a video on my channel that I explain the difference between neuropathic and nociplastic pain. And I created a free handout for doctors. So this is only for doctors, because this is how I differentiate between neuropathic and nociplastic. So if you want to take a picture, you don't take a picture. I think you just point your camera to this QR code and you will be able to download this handout. I can come back at the end and show you the QR code again. So let's talk a little bit about the neuroscience of nociplastic pain. So where does this plasticity happen? It happens in the periphery. The nociceptors, they change. And look when was this paper published? It was published 24 years ago. And what impresses me is that this is still not taught in medical schools. Here in Canada, I hope in India, your students, medical students are learning about this, but here in Canada, it's still not taught, the mechanisms of plasticity of the pain system, okay? So this was published in Science 24 years ago. Where does this mechanism can happen? It can happen in the periphery, in the spinal cord, and in the brain. And what are the mechanisms? We can have activation, modulation, and modification. What does it mean? It means that the pain system, all this periphery, spinal cord, and brain, they undergo modifications. Modulation is reversible. Modifications include gene alteration. So once we have this genetic regulation altered and cells that die, the process of chronic, we are talking about the transition from acute to chronic pain, it's almost becoming irreversible. Although I don't tell my patients that it's irreversible, because I've seen people, the longest one that I've seen was a patient with 50 years of chronic pain, and it was reversed. Okay, so I don't tell them that it's irreversible, because I always give them hope. But this is just an example. This is what happens in the spinal cord. I don't have time to explain to you all the mechanisms, but this is so interesting because, again, this was published almost 17 years ago. And again, a lot of physicians don't know this. This is what happens in the spinal cord. It's called central sensitization. So this is a normal synapses, a painful synapses in the spinal cord. This is the nociceptor coming from the periphery. And this is the second neuron that will send the impulse to the brain. You have an inhibitory neuron here that is able to inhibit the synapses. It's mainly, the neurotransmitters here are glutamate and substance P. But then if you have that synapses continue sending information, you have a hypersensitivity. You see how many more neurotransmitters are in this synapses. In the late phases of central sensitization, you don't need the nociception coming anymore. So here you see there is no more nociception coming from the periphery, but the synapses continue activating itself, sending messages to the brain. And in the late phases of central sensitization, this inhibitory neuron that existed here now doesn't exist anymore. That inhibitory neuron dies. So the brain does not have the ability to control the synapses anymore. So this is a picture that I have in my book. My book is for people with chronic pain, so I explain this in very lay terms. And I explain this. In the normal synapses, you have an injury, let's say an injury in your foot, and you have these two impulses coming from the spinal cord. The spinal cord is normal, does not have central sensitization, and then send two impulses to the brain. So let's say two impulses coming from the foot, and the brain receives two impulses, two electrical impulses. But in the early stages of central sensitization, you get two coming from the foot, But now, because of this central sensitization, the brain receives 5, 10, 50, 100, so it's amplified. In the late stages of central sensitization, you don't need nociception anymore. The foot is healed. There's no more nociception coming from the foot, but the brain continues receiving 5, 10, 50, 100 messages that something's wrong with the foot. But the problem is the central sensitization in the spinal cord. Again, it's the alarm of the body that became sensitized and doesn't shut down. That's one of the mechanisms of opioid-induced hyperalgesia. So I hope you don't have a problem of opioids in India, but here in Canada, we do have, because family doctors love to prescribe opioids to everybody who comes with pain. Orthopedic surgeons, dentists, they prescribe a lot of opioids. They still prescribe a lot of opioids because they don't want to see someone with pain suffering. So if someone comes with pain, they say, oh, I have these opioids that I can alleviate your suffering. Here it is. Go home and leave me alone. But the problem is, if you give opioids to someone who has that central sensitization, remember that I told you about the glutamate? Glutamate is the neurotransmitter that amplifies that synapses in the spinal cord. Opioids do the same thing. So if you give opioids to someone who has nociplastic pain with central sensitization, you're going to give gasoline to the fire. And that's opioid-induced hyperalgesia. So now they have more pain because of the opioids. So we do need to reduce the dose of the opioids, taper the opioids slowly. So I published a paper last year in the Journal of American Medical Association. It's a randomized trial where we randomized 608 people who were taking opioids for chronic pain. And we randomized them to an education and support intervention and to usual care. And guess what? After this intervention, 1/3 of people who were taking opioids for chronic pain, they were taking opioids for many, many years. They stopped taking opioids and their pain did not get worse. So this here is the pain. You see pain did not get worse, but 29% discontinued their opioids. So why were they taking opioids? If the pain did not get worse, their function got better. We measured sleep, we measured mood, constipation, everything got better. Pain did not get worse, and they stopped completing the opioids. So I hope you don't have a problem with opioids in India, but here we do. Let's talk a little bit more about what happens in the brain. So remember I told you that I told you what happens in the plasticity in the periphery, plasticity in the spinal cord, now the brain. A lot of things happen in the brain. So the brain responds and becomes hypersensitive, hypervigilant. So a person with back pain, they measured the amount of gray matter density and they have decreased. They have decreased gray matter in the prefrontal cortex and in the thalamic gray matter, which is very important for the processing of painful sensations, to the point that a person that has chronic back pain is equivalent to a person that is 10 years older. So we are talking about losing brain matter, which is very important, putting these people at a cognitive impairment. So you may hear people with chronic pain saying that they have difficulty concentrating, they have difficulty reading a book, they have difficulty working, they get lost. That's because they are mildly cognitive impaired, because they are losing cognitive, they're losing gray matter because of the pain. That's what the pain does. That, remember, they are not having nociception coming from the periphery, but the brain still thinks that they are in danger all the time. Another thing that happens is functional reorganization. The default mode network in the brain, which is the connections of the brain with other parts, it's not only important to have gray matter, but also it's really important to have connections between parts of the brain. And we know that in people who have chronic pain conditions, all of those, chronic back pain, CRPS, complex regional pain syndrome, even osteoarthritis, they have abnormal connections in the default mode network. Not only this, but the insula, which is part of the limbic system, is also altered in chronic pain patients. Because normally, if you have an acute pain sensation, any person that does not have chronic pain, if you expose them to acute pain, they're going to stimulate the anterior insula and then the posterior insula. In people with chronic pain, they have an abnormal response to acute painful stimuli, which now every acute pain that they feel, it's much more emotional, much more alarming, much more troublesome than in a person that does not have chronic pain, because the insula alerts the pain, alerts the brain that, oh, this is really unpleasant, something really dangerous. So a person with chronic pain who has already abnormal brain functioning feels acute pain very differently, very differently. I know this is a little complicated, but I'll try to simplify here. So what's happening here, normal conditions, our HPA axis, the hypothalamus, pituitary, adrenal cortex that produces adrenaline, cortisol. Under normal situations, we have an acute stressor. Let's say you are walking in a forest or in a ravine and you see a bear. Well, you don't see bears in India. Maybe you see an elephant. You see a big elephant in front of you, and that's an acute stressor. You say, okay, what's going to happen? It's me and the elephant. Is it going to run over me? So your amygdala activates the hypothalamus. The hippocampus inhibit. So once the elephant goes away, the hippocampus says, it's okay, let's go all back to normal. Amygdala, stay quiet, you don't need to alert, the elephant is gone. So in a normal person that has, it's facing danger, this is what they have. And the production of glucocorticoids, adrenaline, they connect with the mast cells. Remember, I told you the immune system, this is a connection here between the pain system, the neuroendocrine, and the immunological system. They are responding to stress. This is the ascending pain pathway, and this is the descending pain pathway. I didn't explain to you very well the descending inhibition, but the brain has the ability to inhibit pain, and this is this blue line here. Now, in a sensitized brain, again, if a sensitized brain can be a person that lives with chronic pain, they have a sensitized brain. Or a person that had a motor vehicle accident or a work-related accident, or their pain was caused by a very threatening event, or a person that their childhood was very traumatic, so they had a lot of early life stress. This stress system, this HPA, hippocampus, amygdala, they are not working the same. They are abnormal. They don't respond well to an acute stress because they are already under chronic stress. So in a person with a sensitized condition, the amygdala is super active. The hippocampus is kind of absent. The hippocampus is unable to inhibit this. They have a lot of adrenaline, a lot of cortisol. The mast cells are super active. They have all of this ascending pain pathway sending a lot of pain impulses to the brain, and the descending inhibitory pathways are inactive. I will show you another slide that I show you how we can fix this. It's so beautiful. So when does acute pain transforms into chronic pain? The process starts immediately. It starts with spinal cord central sensitization. Cortical reorganization takes longer and involves long-term potentiation. It's almost like the memory of pain. So if you study memory, if you know how people make memories, like how do you learn piano? You practice, and then you learn how to play the piano. If a person feels pain, their brain learns how to feel pain. So you create LTP, long-term potentiations in the brain, and that pain becomes like a memory. It's exactly the same mechanism. They lose the ability to inhibit the pain in the periphery. They have some irreversible epigenetic changes. This process usually starts by 3 months. So do not prescribe opioids if you suspect nociplastic pain. This is a little complicated slide, but it's so important because we did not know exactly when. Everybody said 3 months is mainly when the pain becomes chronic. Those changes started happening. And this paper published, I think they published in 2013, they showed exactly it is at 3 months. So what's happening here is they got people and they examined their brains and they did a lot of questionnaires and a lot of physical examination. They recruited people who had subacute back pain. So these people did not have chronic pain. They just had a acute or subacute back pain. And then they followed these people for 1 year with brain imaging, with questionnaires, physical examination. And look what they found. So initially, was in the, and they classified, these are the pictures of people who persisted with pain for 1 year. And you see there are still some images in their brain is still lighting up here. And SBPR are those people that they had subacute back pain, but they recovered. So 1 year later, they don't have anything showing pain in their brain. So they looked at the differences, the trajectory of what happened, and look what happened. In those who persisted, their brains, it was the blue is the emotional areas. All the emotional areas of the brain started by around 12 weeks, 10, 12 weeks, their areas of emotion started going up, 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 up. The area of nociception, the red here is the somatosensory, started going down, 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 down. So no more nociception. And the chronic stage, they had the emotional areas of the brain. So again, if you see someone with chronic pain, if they don't have nociception, they don't have nociceptive pain, they don't have neuropathic pain, what you would see in their brain is all the limbic system areas of their brain would light up. That's why they're depressed, that's why they're anxious, that's why they're debilitated, because it's a disease of the brain now. And their pain is real, okay? We're not saying that they're imagining this pain. This pain is very real and very constant and very intense. In people who recovered, look what happened to the brain. Everything went down. Okay, so chronic pain is one of the most underestimated healthcare problems in the world today. Unfortunately, it affects 1 in 5 adults and 1 in 3 seniors. That's why the International Classification of Disease with the WHO, in the last revision of the ICD-11, they created a new term, which is chronic primary pain. So chronic pain now has a name, and it has a place in the ICD-11. And we can, when the pain is not nociceptive, is not neuropathic, you can say this is chronic primary pain, which means the pain, the origin of the pain is in the pain system, is those neuroplastic changes, okay? And there is this is the guideline that I mentioned to you for chronic primary low back pain, just released a couple of months ago. And in this guideline, they say 90% of chronic low back pain is primary pain. Previously, we called this non-specific back pain because it was not neuropathic, it was not nociceptive. Okay, let's talk about treatments. I'll quickly talk about how we can revert nociplastic pain. So we know that if it's a disease of the brain, we need to treat the brain. It's the brain and spinal cord, but if you focus on the brain, that's where the gold is, because the best treatment for chronic pain is, that's why I say the physiatrists, we are the best specialty to treat chronic pain, because that's what we do. We do rehabilitation of brain injury, stroke. We use neuroplasticity all the time. That's what we do, okay? Even neurologists don't know this. And neurologists, they treat migraines. Migraine is a type of chronic primary pain. But look, cognitive behavior therapy reverts. Remember that I told you that they lose gray matter? If you do cognitive behavior therapy, they showed this, that you can increase the gray matter. You can revert that loss in the gray matter with cognitive behavior therapy. Look, you are in India and you have yoga. They have done research with yoga and showing that yoga reverts those changes in the brain because of the meditation, because of the exercises, because of the breathing, because of the stretchings, the positions. Yoga showed the longer the person does yoga, the more hours they do yoga. But not only this, this is so interesting because they showed that people who did yoga, they use different methods to interpret their pain, which is more like the breathing, observing, accepting, relaxing. But people that did not get better, they were in the control group, they used distraction, ignoring the pain, negative emotions, did not work so well. Another way to treat chronic nociplastic pain is pain reprocessing therapy. I don't have a lot of time to explain this to you, but this is a kind of mind and body intervention. You do exercise with the body, you do exercise with the mind, and you reappraise what you think the pain is coming from. This was published more recently, I think 2021. Remember that I showed you that slide before that the stress response was abnormal. Here is exercise for the body and cognitive behavior therapy. So the green and the purple here, they revert these problems here. If we do exercise in CBT, look, the hippocampus increase activity, you increase gray matter in the prefrontal cortex, you inactivate, you kind of inhibit the HPA axis. So there are things that we can do. So when I explain all of this to physicians and my colleagues, I say, remember the 5MIS management of chronic pain. So the first M is mind, the second M is movement, and then the other M's are modalities, manual therapy, medications, the I and S are interventional and surgeries. We can use all of this 5MIS to manage chronic pain, but you do need to know, am I treating nociceptive pain? Am I treating neuropathic pain? Or am I treating nociplastic pain? Because for each type of pain, you're going to use one of these interventions here. Not all of them for all patients, but remember what are you treating. So that's the end of my presentation. I do have a lot of videos on my YouTube channel that I explain these things. I also talk about diet, exercises. I talk about sleep. I talk about what is pain, the 3 types of pain. And for doctors, I have courses on my YouTube, on my website. This is my website, drandreafurlan.com. And if you come here, courses, I have courses for doctors. And if you come here about pain, I have a lot of free handouts for patients that want to learn more about pain. So thank you very much. This is the end of my presentation.
Thank you very much, ma'am. Hello.
Yes. Anyone have any questions, Nitesh? Or maybe Dr. Chandanpreet?
Dr. Andrea, that was a wonderful and very mesmerizing presentation. I was listening to it with full intent and very honored to have you as this first presenter. And it was eye-opener, and I think a lot of our students have benefited. You being a physiatrist, that what physiatrists can do, what extra we can do, and how the pain has to be managed. No questions from my side, but I will definitely like to learn more from you. I thoroughly enjoyed it. And
yeah, so if you want, I can post again that link to download the free handout. I don't know if, or I can, I will put here in the chat, maybe I'll put in the chat the link for people to download that's how I explain how I differentiate neuropathic, because for me, the most difficult is to find out when a pain is neuropathic or nociplastic. So I created that handout to teach my students, my residents, my fellows, and I'll put here in the chat for you to download that. Let me see, where's the chat?
Andrea, it would be better, like if you can just forward them to us, because our students might get, benefit out of it. Thank you really so much.
Yeah. So yeah, you can go there and download it, and then I'll have your emails. If you go to that link that I just put on the chat, just enter your email and then immediately you download that handout.
Great. Thank
And
you.
then I like to get the emails of people because if I am updating that handout, I'll be able, I'm thinking I need to update that handout. So if I have the emails of people who downloaded, they will get the updated version. And anything that I have updated, I'll send to everybody that I have the emails.
Great. Thank you
Great.
so much.
We do
It
have a
was it
question.
was it was excellent talk, ma'am. First, actually, as the Academy of Pain Physiatrists, we are really grateful to accept our first invitation as inaugural webinar, and it was really eye-opening webinar. And actually, we are as a physiatrist, as you mentioned, that physiatrist can be the best pain physician. Even we really think of it is really true thing. Because many of our colleagues, they are mainly thinking of only of interventions only.
Yeah.
As your slides you have mentioned, in low back pain, the 90% of cases of nociplastic pain, usually we think of neuropathic pain, which is more common. But today we got actually the opportunities to learn about nociplastic pain also. And now onward, we can take more of advantage from your side also. And hopefully in future also we have a good presentation from you and good support from your side.
Yeah, I'll be happy
Yeah.
to come back. Yeah.
Yeah, sure. Even
I'll
we'll
be
call
happy.
you India in a physical form also in our upcoming
Oh yeah.
conference.
Oh my
which
God.
is-
I've never been to India.
Yeah.
Maybe
Yeah.
if
Oh,
you invite
great.
me, it would be
We
my
shall invite
pleasure.
you, don't worry.
Yeah, we'll
And
surely
it's a
invite
very
you.
well attended webinar. So there is 68 participants. I'm looking at them, like,
Yeah, that is excellent.
yeah. Chandan, any question in the
Yes,
chat box?
there are questions. One is from Dr. Sanjeev Sharma. He says, can you throw some light on the role of diet and exercises in the management of fibromyalgia?
Oh, I'm so happy with that question. Oh my God. Thank you so much for this question because this is so important. Well, I could give you another 1 hour lecture just about that. I actually have a lecture about a diet for fibromyalgia, and I have a video on my channel that I teach because I talk about this with my patients all the time. When we try to revert nociplastic pain, again, nociplastic pain, if you think it's a disease of the whole body and it affects the biopsychosocial, diet, exercise, sleep, social connections are the main thing that is going to revert nociplastic pain. Okay, it's not medication. We tend to, there are some medications that are approved to treat fibromyalgia, but I never had one person that came to me and said, oh, I was taking duloxetine or pregabalin and my fibromyalgia got so much better. They usually get better. The sleep gets better, the stress gets better, the anxiety, but the pain usually doesn't. Really, what helps people with fibromyalgia is exercise, mindfulness, meditation, cognitive behavior. It's thinking differently about what they have, being believed. I think if you believe in them and you say, I know you are in pain, you are in a lot of pain, and I'm going to help you. You are the first doctor that probably is going to tell them this, okay? And then start changing their lifestyle. So try to see if they have any lifestyle that is terrible, and they usually have. Usually, in terms of nutrition, the first thing that I try to introduce to their nutrition is get rid of junk, processed food. So stop eating processed food, salt. Stop eating anything that contains a lot of glutamate, because remember, glutamate is that neurotransmitters that predispose to central sensitization. And start eating more fruits, vegetables. If they can eat meat, then I recommend them to eat cold fish water, fish from cold water, because that contains a lot of omega-3s. But if they are vegetarian, that's okay. They can eat their omega-3s from other sources, extra virgin olive oil, flax seeds. It's so important that they increase omega-3s, stop processed food, and introduce more vegetables and fruits. Because of the antioxidant. So yeah, I could give you a lot of hints. And the other thing was exercise. Yeah, exercise for fibromyalgia is extremely important, but because In fibromyalgia, one of the main mechanisms that why they have a lot of pain is because the descending inhibitory pathway is not active. So remember, I told you the ascending pathway that goes from the periphery to the brain that can be hyperactive even in the absence of nociception. So it can be hyperactive, or the descending inhibitory pathway from the brainstem down that we have the ability to inhibit pain. In fibromyalgia, it's abolished. So the only way that they can, and that's why when they exercise, they feel a lot of pain, because when you exercise, we all feel a little bit of pain, but then if you are a normal person without fibromyalgia, your brain will start releasing those endorphins, enkephalins, dynorphins, which is our endogenous opioids, and will abolish that pain after exercise. But in people with fibromyalgia, they cannot. So they feel all that pain after exercise. So they don't want to exercise because it hurts. But we do need to start gradually. And I tell them, when you are starting to exercise, you are opening the door of the inner pharmacy that you have in your brain. So your brain is starting to produce endogenous opioids again. It will take time, but we're training your brain again to activate that inhibitory descending pathway. So they love it because they say, okay, now I know I'm feeling pain after exercise, but I know what I'm doing to retrain my brain. I also have a video on my channel. It's called the brain's inner pharmacy. So they have to start slow and know why they are doing to get motivated to continue.
Can we take another question, please?
Yes.
So, Dr. Sumed More, he wants to ask, what is the most commonly prescribed CBT, cognitive behavior therapy, in your practice?
Yeah. So there are a couple of different types of psychotherapies. CBT, I find so hard for me to find cognitive behavior therapy here in Canada because it's delivered by psychologists. And here in Canada, psychologists are very expensive. They charge a lot per hour. And most of my patients don't have, money to pay for cognitive behavior therapy, unless if they are working, they have some benefits. So we need to be creative. We need to be, I need to help my patients to find. So I tell them, if it is too expensive for you to access a psychologist, maybe there are some online sources. They do find psychologists that offer online, or sometimes social workers that do psychotherapy for pain, but they need to see someone like a professional that understands chronic pain. Not any psychologist will understand all of this that I mentioned to you. That's the problem. Or social workers, or counselors, mental health providers that understand pain, chronic pain, the neuroplasticity, because they will go straight to those maladaptive thoughts that the person has. And cognitive behavior therapy will help the person to think differently, to lose the fear of pain, because a lot of people are trapped because of the fear of pain, because they feel pain and then they think something's wrong with my body. Because when we feel pain, immediately you think, I need to fix that. Something's wrong, something's damaged, something's broken. But in the case of chronic pain, there's nothing broken, nothing damaged, nothing. The pain is just a false signal. It's the alarm that is making noise, but again, the kitchen is not on fire. So they need to learn that. They need to lose that fear of pain. Fear is the fuel of chronic pain. I'll say that again. Fear is the fuel of chronic pain. If the person continues having fear of pain, they stop their lives. They stop living. So the cognitive behavior therapist will help them to say, listen, you can go for a walk. You're not going to break your body if you go for a walk. You're going to feel pain. I know the pain is real, but go for that walk, because if you go, you're activating your brain, blah, 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 blah. So they will feel pain, but now because they're losing their fear, they went for a walk, let's say 500 meters, they came back and they say, yeah, I have pain, but so what? I would have pain if I went for a walk or not. So I better go for the walk and have the pain instead of staying in my sofa, my couch, and have the pain. So they start retraining their pain system. And the more they exercise, the more those abnormalities in the brain will be undone. So that's why it's so important to do cognitive behavior therapy with movement, with exercise.
There's another question. Can we take that too? Yes.
Yes, I can.
Yeah, that's from Dr. Nagma. She wants to ask that, can you please briefly discuss about the drugs to be given used in nociplastic pain?
Okay, so if we think the person has nociplastic pain, the first thing is no opioids. No opioids. But what can you give instead? So I usually see if the person is very depressed, and I use the PHQ-9, you can download the PHQ-9 on a website. Then I start them on a SNRI, a serotonin norepinephrine reuptake inhibitor. That would be either duloxetine or venlafaxine. I also like amitriptyline or nortriptyline tricyclic antidepressants. I try to use for a short time just to improve their depression, so they can get some energy, some serotonin in their brain to get up, because I have patients that they are in bed all day, like young patients. I have a mother of 2 kids. I think she's 32 years old, and I'm still trying to rehabilitate her. She doesn't leave her bedroom. She told me she leaves her bedroom once a week. Fridays, she leaves in the end of the day just to see her kids, and then she comes back to her bedroom. So she's a terrible depression, terrible pain all over her body, a lot of trauma in her childhood. So it's a terrible situation, but we are trying with psychiatry, with antidepressants. So I use those antidepressants if the patient has nociplastic pain plus depression. Now, if they have nociplastic pain plus neuropathic pain, then I use the medications for neuropathic pain, anticonvulsants. I may use some Nabilon, which is a synthetic THC. I may use amitriptyline if I find that they have some neuropathic pain going on, which, some people have mixed pains. Nobody said that they can only have one type of pain. They may have nociceptive neuropathic and nociplastic pain, which complicates everything. Our population of patients, they may have a mixed neuropathic and nociplastic. But just to treat the nociplastic pain, there is not one medication that will say, okay, give this medication, the nociplastic pain will go away. No, it has to come from lifestyle modification, mainly the mind and the movement interventions. And you have yoga there.
Yes.
Yeah.
You have one of the best interventions in the world.
Additionally, there are a lot of thank you messages to you, ma'am, from all the people who have joined.
I'm glad. Yes, I'm glad. Yeah. Okay, maybe I'll save the chat and I will read the message. How do I save? I know there's a way that I can save the chat. Let me see. I can't find, okay, here. Save chat. Okay, I saved the chat in my computer so then I can read those messages later. Yeah. Thank you so much for inviting me.
Thank you very much, ma'am.
Thank you, Dr. Andrea. Wonderful to have you here. Wonderful. Your talk was awesome. Thank you.
And I'm so glad that you physiatrists are taking pain seriously. Congratulations on your initiative.
Thank
We
you.
do need more physiatrists, residents of physiatry. We do need them to learn all of this because we are the best specialty. I'm sure, I have no doubt, to treat chronic pain.
This is
Thank
the
you
main
so
objective,
much.
ma'am, to form this Academy of Pain Physiatrists.
Thank you.
The main motto
Namaste.
behind
Thank
it.
you.
Yeah. Thank you.
Hello,
Thank you.
everyone.
Thank you
Sir,
so much.
sir, Nitesh, sir.
Yeah.
Please,
Yeah.
everyone, please open your camera. We can take a screenshot.
Yeah.
So can I leave now?
Yeah. Sure, ma'am. Sure.
Thank you, Nitesh. Good to see
Thank
you
you,
again.
Andrea. Yeah.
Thank you.
Yeah.
Thank you,
We need
ma'am.
to take a screenshot with Dr. Andrea as well. So,
Ma'am, please wait. We are
yes.
taking
Oh,
a
yeah?
screenshot with all participants.
You want a picture? Okay, yeah. Oh, I will take a picture too. Can I put this on my social media? I will put
Yeah,
on
sure,
my...
ma'am. Then.
Can I? Okay, let me take a picture too. Where's my picture? Okay, wait. I'm just wait. Okay.
Okay, thank you, everyone.
Okay,
Thank you.
wait. Everybody's smiling.
Dr. Andrea is taking a picture as well. Let's see.
I'm taking a picture. Okay, smile.
Thank you.
Amazing. Thank you so much.
Thank you.
Thank you. Thank you.
Thank you.
Okay.
Thank you. Thank you,
Bye.
Chandan.
Thank you.
Nitish, to carry out the proceeding in such a beautiful manner. Thank you very
Thank
much,
you.
everyone.
Thank you.
Thank you,
Bye-bye.
everyone. And thank you, Dr. Andrea, once
And
again.
we have a good day ahead. Thank you.
Good.
Thank you all. Thank you.